Welcome everybody to this St Mary's webinar series. Today the subject we're going to be discussing is how to rebuild the NHS after COVID and to ensure that the NHS is resilient and built for the future. My name is Jenny Willott. I am the Director of Enterprise and Innovation at St Mary's University, and I've been asked to moderate and chair this session today. We have two very interesting speakers who have very different perspectives on this subject, and hopefully will be providing very complementary comments which would hopefully lead to some really interesting questions at the end. So the first person who's going to be speaking is Professor Andrew George. So Andrew is the chair of Imperial College Health Partners, and he's also a non-exec on the Health Research Authority and on Health Education England. And so he's going to be speaking to us from that perspective. So Andrew, over to you.
Thank you. Thank you, everybody. My name is Andrew George, and I'd like to thank very much Jenny and the team at St Mary's for having this event, a very timely event at the moment. So to start with the obvious, I mean, SARS-CoV-2 has had a massive impact on society, both in this country and around the world. We've had an estimated nearly 42,000 deaths in the UK as a result of this. And all of us have experienced restrictions, including lockdowns and everything else that has impacted everybody. And the one thing that we will know is that the world that we emerge from will be different from the world in which we entered this. And so today I'm going to be looking with Norman at the NHS, a key aspect of this. And the impact on the NHS of COVID-19 has been massive. It's led to structural changes. For example, a rebalancing of power from individual providers such as NHS trusts towards systems that are run on a regional level. And it's also produced changes in the way that the NHS works. And now most of these changes were happening anyhow, but what the pandemic has done has to be really accelerate them. There's also been a big impact on the public perception of health. And this has included a realization of massive inequalities in health as a result of socioeconomic disparities and also embedded racial discrimination. And there's been a massive outpouring of support for the NHS. Nigel Lawson said some time ago that the NHS was the closest thing we had to a national religion in the UK. And this was seen on the Thursday Clap for Carers, as well as recently this massive increase in people applying to work for the NHS. So for example, this year, applications for nursing degrees are up by 15%. There's also been the beginnings, and I'd only say the beginnings, of a debate on the personal responsibility for health. And we need to build on that so that people understand and accept how the choices that they make can impact on their health, and the decisions they make can help them live a more fruitful and healthier life. So what we've done is that we've seen changes in the NHS that would normally take more than 5 years to happen within 5 weeks. And these have included remote consultation, structural reorganisation, and a willingness to embrace innovation. But moving forward, as part of the context, we have to say we're faced with some massive problems. And these include the indirect impact of COVID-19. So some expert observers are predicting that more people will die because of COVID-19 than of COVID-19. Now, these numbers are very difficult to estimate, but there's a bundle of studies that suggest that excess cancer deaths will be between 3 and 10,000. Though some commentators are considerably more pessimistic and suggesting 50 to 60,000 excess deaths. During lockdown, deaths related to heart attacks rose by 40%, and the British Heart Foundation estimates there have been more than 3,600 excess deaths from heart and circulatory disorders as a result of COVID-19. And this number may well increase in time due to long-term consequences of late diagnosis and the resulting inadequate treatment early in the disease. Now, these numbers are all estimates, and they're almost impossible to get to tie them down, but they do demonstrate the indirect impact that COVID-19 will have on our health over the next few years. And one area, of course, that's especially critical is mental health. And I'm not going to speak much about this because I know Norman will be wanting to speak more, but there is clearly a massive short and long-term impact as a result of the anxiety and stress caused by the fear and the social dislocation and the economic downturn, and the impacts on the NHS staff and patients who have been recovered after many months in ICU and who have PTSD. Again, there are estimates from the Centre for Mental Health who estimate around 500,000 additional cases of mental health following COVID. And then there will be the impact of the inevitable economic downturn. This is going to stress the NHS by increasing health inequalities, increasing health needs, and also reducing the funding available to health. And in the short term, we may also be facing a loss in confidence of people in the ability of those in power to deliver the changes and that may impact on the necessary behavioural changes that people need to do. So we need to deliberately think about what we change in the NHS in response to COVID-19. There are things that we have changed during the crisis that are good and that we need to continue. Other things were the right things to do in an emergency, but we need to stop and revert back to normal. And then there are some things that we stopped doing that we need to restart, and other things that we stopped doing and actually we've realised that we don't need to restart them. So there's a real opportunity here. We need to make a decision as to what sort of NHS we want and look towards an NHS with a better and a more sustainable health service. Now, I'm only going to be able to touch on a few of these, but I'm going to touch mostly on workforce and a little bit about transparency and how we can use that in the NHS. So what we need to do when we think about the NHS and the direction that we want to take the NHS in is that we need to put the patient at the centre of our thinking. We need to think about what support the patient needs to maintain their health and well-being. And we also need to think what's important to them in their health, because far too often healthcare is focused on what's important for people rather than what's important to people. Now, the factor that most limits what we can do are the people that work in healthcare. Getting enough of the people with the right skills in the right teams is critical. The shortage of people is going to be the greatest limitation, greater than money, for the future of the NHS. Now, the current government has a manifesto commitment to increase the number of nurses by 50,000 in the term of this Parliament. And this is ambitious if you think there are about 290,000 nurses at the moment. But most commentators think that this will not deal with rising demand in the future. So there's no doubt we need a workforce that is larger, but we also need a workforce that will work in new ways, that will have improved care and be more efficient. And there's several changes that we need. So one of these is crossing disciplinary silos. And now these include professional silos. At the moment, there are clear demarcation between professions such as nurses and doctors and physiotherapists and psychologists. And there are also boundaries between disciplines, cardiovascular disease, cancer or whatever. Now, these silos can be inefficient and they also reduce the quality of patient care. So, for example, a patient may be visited at home by a specialised nurse who will decide on the care needed, but will then instruct a health visitor or a more junior person to carry out a procedure, such as changing a catheter. This is neither efficient nor is it good care. And there was also increased emphasis on working in teams, with the specialists in the team providing a training to others so that they are empowered to support the patients. So one mental health trust I visited recently was educating clinical psychologists during their doctoral studies to teach other members of the team, including nurses and doctors and healthcare assistants, how to provide the simple, straightforward psychological support. The expert psychologist role then becomes dealing with complex cases and supporting and training other members of the team to deliver the simple work. And that's what we need to do across our professions more in the NHS than we're doing at the moment. During the COVID pandemic, circumstances have forced similar team working. So, for example, the result of many patients being ventilated is that there are many patients on hospital wards who have had tracheostomies or breathing tubes put in through their neck. Now, these are normally cared for by specialist teams on the specialist wards, but that just wasn't possible during the pandemic. So at the height of the pandemic, most acute hospitals in the major centres set up specialised tracheotomy care teams. And these consisted of physiotherapists, dietitians, speech and language therapists, CNSs and others, as well as online medical support. And these were rapidly trained to go around the hospital, teaching the nurses in the local wards how to provide routine care for their patients. And the team's role was to provide support to these people, to help when things were complex, to do a daily review, and to take the critical decisions. There's also, during the height of the pandemic, been an increased emphasis on distributed leadership, where people who would normally be thought of as lower in the conventional hierarchy are given control. So an example of this is an ICU, which are traditionally very doctor-led. Now, patients with COVID-19 in ICU will often benefit from from proning, that's being placed on their front. Now, this is a really difficult procedure to do on sick patients in ICU, and proning teams typically have a staff of 6 people to do this procedure. Now, in many centres, they found that the best people to lead these teams are actually the physiotherapists. And so while the teams have anaesthetists in the team, and they have a vital role of maintaining the air supply to the patient during the procedure, they are not leading the procedure. And this is just a small example of how patient care can be best provided if people change the conventional hierarchies. So the need to bring people into healthcare systems means that we need to look at improving access to the healthcare professions. There are large parts of the population that are not sufficiently attracted to work in healthcare. And this is an ongoing issue, but there's considerable work to improve pathways, not only so people can be recruited to associate roles and then progress on, so for example, from a nursing associate to nurses or physician associates to doctors, but also so people can move between professions. It's also really important that we work to make sure the NHS is a good place for people to work so that we retain our staff. And there's also a need for medical professionals to increasingly use technology to enhance the care they give. Now, this is an area of considerable interest to myself, and technology, including wearable devices, remote sensors, as well as artificial intelligence and the intelligent use of big data, can make healthcare workers more efficient and also deliver better care. And this is not something that is just pie in the sky for the future. So, for example, Surrey and Borders Partnership NHS Trust, which I'm very pleased to have a connection with, has been working with academic partners to develop technology integrated health management. And these are monitors that can be used for patients with people with dementia. And they monitor vital signs and they monitor movements. And they are then feed into machine learning, which allows those who are responsible for the care to be alerted to unusual behaviors, for example, agitation. This is not something that's happening in the future. This is now being rolled out across Surrey. And so this allows care to be delivered, better care to be delivered more efficiently. We're also in the process now, accelerated very much by COVID, of rethinking how our medical professions need to be. So Health Education England has just published a report on Future Doctor Programme, which talks about how the medical profession will have to change. It suggests that doctors in the future will have to have their patients front and centre, something most doctors do automatically, but also that they need to be more generalist than present, and that they will need to lead and collaborate in multidisciplinary teams, that they will need to focus on the health needs of the population, not just of individuals, and that they will use research and innovation to improve care, and that they will have a prime goal in doing that. So the final area I want to touch on is improving decision making and making it more transparent. The backlog of procedures since March has meant that surgeons and other clinicians have had to prioritise patients. This is inevitable. However, in the past, this has been difficult to do in a way that is just and equitable and takes into account the particular needs of a patient. The only thing that was considered were crude waiting times. So one response that's been developed in Imperial College Health Trust, and it's now being widely adopted across the country, has been to develop a harm matrix, which provides a framework for assessing the potential harm to individual patients as a result of any delay. And this allows a rational prioritization of care, which takes into account individual needs rather than using universal weighting targets that inevitably distort provision and reduce the overall benefit to patients. So in summary, I'd say COVID-19 has had a massive impact on the NHS and the challenge is continuing. However, the response has been to drive change, and much of this has already happened and is already ongoing. But what we have to do at this time is to actually envisage what we want the future to be, so we can build an NHS that is actually resilient, is efficient, is equitable, and places the health of patients and populations at the heart of what it does. The workforce is going to be critical for this, and we need to ensure that those working in the NHS are equipped with the skills and the attitudes that are needed for this new way of caring. So thank you very much, Jenny.
Thanks very much, Andrew. Lots for us to think about. Just before I introduce Norman, just to say, if you have questions, and please do ask questions, for either Norman or Andrew, or in response generally, then there is a Q&A function at the bottom of your screen. So please pop your questions in there, and we'll come to them after Norman has spoken. So it's my pleasure now to introduce Norman Lamb, Sir Norman Lamb, who is a former health minister responsible for care and support. He is now the chair of the South London and Maudsley NHS Trust, which is a mental health NHS trust. And he's also the chair of the Children and Young People's Mental Health Coalition. So over to you, Norman.
Thank you very much indeed, Jenny. And it was very good to follow from Andrew, and I very much agreed with the contribution that he made. I think it's clear that the NHS faces an existential challenge now as a result of this COVID crisis. The system before this happened was already under pretty incredible strain. Now that has been made significantly more challenging, and it seems to be overall that the NHS will have to change in order to survive. Now, Andrew has described many ways in which we can get better value from the money that we spend on the system. That will be absolutely essential in both physical and mental health care. And necessarily, I think it also involves the patient being at the heart of decision making in a way that they haven't always been in the past. I wanted to start by saying something about the sort of psychological fallout from this COVID crisis. We know from previous recessions and indeed from previous pandemics that there is a psychological fallout. We're starting to see that happen, but there's a lot further still to go. We haven't yet seen the full extent of the impact of unemployment on the mental health and well-being of our country. That will become clearer in the months ahead. But if you think about risk factors associated with mental health, isolation, loneliness, financial anxiety, build-up of debt, unemployment, damaging your sense of self-worth and your dignity, all of these things, including, of course, also bereavement, are present at the moment. Combine them all together, and there is a potentially quite toxic mix. And the implications, therefore, for the mental health system across our country are considerable. We're seeing increases in demand, which Andrew mentioned. We're seeing an increase, therefore, in out-of-area placements. This is this awful practice of patients in crisis having no bed to go to locally, and so being sent some distance away from home. The number of places, inpatient beds we have available has been constrained because of COVID and the need to separate patients who haven't yet been tested from those who have been cleared for inpatient care. But the result is a significant increase in pressure on the overall system, and also a phenomenon of many patients being held for far too long in A&E departments before getting access to a mental health bed. So the system is already under significant pressure, and that I fear will simply grow much further. And there is also, incidentally, a race dimension to this that we have to seek to understand and to confront. Just as we know that the physical health crisis of COVID had a disproportionate impact on many BAME communities, so I think it's likely that the psychological fallout will also impact those communities, those same communities, and communities which are more disadvantaged. So where the sort of economic impact of the crisis will be greatest. So that has to be confronted. It's also important to recognise, I think, as Andrew described, that there have been some positives in how we have responded to COVID. The dramatic increase in the use of virtual communication. I was told that within my trust, there had been a frustrating failure to spread the use of Teams, the Microsoft virtual conferencing system. Very few people willing to really embrace it. But within a week of the crisis developing, everyone was using it. And there was this remarkable can-do attitude, which has been sustained. And that is to be applauded. And it's not just the fact that we are able, between professionals, to communicate more effectively. And I've seen clinicians collaborating and comparing notes on Teams meetings in a very impressive way. But also, of course, the virtual consultations with patients, many of whom struggle to get into clinics. And that's been a real opportunity that has been grasped. But we should also remember that there are people who are not digitally connected, and that's particularly prevalent amongst many of those who have severe and enduring mental ill health, and they must not be forgotten about. And also, people in mental health crisis very often cannot be dealt with simply virtually. They need a personal contact, and those people must not be forgotten about in the midst of all of this. So that's what we've been through. We now face an extraordinary financial challenge, and I would say across the NHS. So we had 10 years of the tightest financial settlement in the history of the NHS. We've been used to 4% year-on-year increases over the history of the NHS. Over the period of the coalition government, it was about 1.5%, and it hasn't been much more than that since. We now have a settlement that delivers 3.5%, but that is clearly below the historic average after the toughest period in the history of the NHS. So there's no catching up being done, and the NHS has not been good at delivering efficiency savings that has been imposed on it. So, and then you look at the state of our public finances coming out of this crisis, and the challenge for any government would be massive. And so I'm really anxious about how we sustain the NHS financially in the years to come, given the state of public finances as they are at present. So that forces on us to think more creatively about how we spend money within the system. And I have a particular concern, incidentally, about capital spending. Across the mental health system, we have conditions that are, frankly, completely unacceptable in this day and age, where we place patients in mental health crisis. We too often put them into inpatient wards that are Victorian in nature, that are simply not fit for purpose and certainly not therapeutic. Now that will force upon us fresh thinking. We're going to have to be willing to become more commercial, it seems to me, at exploiting, in the best possible sense of the words, our estates, to ensure that the value of those estates can be fed back into improved modern mental health care. If it's not going to come from public resources, we're going to have to find ways of exploiting our estates to deliver additional resources for mental health. And there are opportunities for us in our trust to do that. We also, I think, will have to start thinking more about collaborations between public and private sector. If the state isn't going to be able to build new facilities that are fit for purpose, then perhaps collaborations with the private sector may be a way of doing that, and we have to be open-minded about our willingness to do that. But then beyond that, we also have to think about where money is spent in mental health. And the truth is that in this country, we have longer lengths of stay than the international average in both children's mental health and in adult mental health. And so we're spending a greater percentage of the money that's available to us effectively on containing people in institutions which are often not fit for purpose and which do not aid recovery. Now, the national policy framework, and it's enshrined within something called the Community Mental Health Framework from NHS England, is to shift care as much as we're able to from inpatient care to community support. And it's a policy approach that I very strongly endorse. I was struck back in early February visiting Trieste in northern Italy. I visited Trieste just before the world closed down and just before northern Italy was consumed by the virus. But what I saw there was a system that relies much less on hospital beds and far more on supporting people in the community. I asked them how much of a problem the use of restraint was in their system. In our system, it's endemic. People experience physical force used against them in inpatient settings. And again, there's a disproportionate impact, particularly on young black men, an uncomfortable reality that we have to confront. The response I got in Trieste was, we don't use restraint here. I asked about waiting times for mental health support. We don't have waiting lists. And the reason for this is that although they have a smaller budget for mental health than we have in this country, they're spending a far greater proportion of that budget on community support, on intervening early to stop a deterioration of health in the first place, and to support people more effectively through crisis. So that forces us, it seems to me, to think in a new way, in a fresh way, about how we can best support people. There is very little, if any, evidence to support long-term institutional care in terms of therapeutic recovery. We too often ultimately end up simply containing people in unacceptable facilities. And so let's be more ambitious for people with mental ill health. Let's focus our resources on intervening early to stop mental ill health in the first place, to stop a deterioration of health when it has already emerged, and to support people more creatively through crisis, as we know happens elsewhere, to stop the need for expensive inpatient care, which does very little for people's sense of dignity, their sense of self-worth, and does very little for their recovery in many circumstances. Yes, we will always need hospital support for those in crisis where everything else has failed, but I believe that there is a significantly more enlightened way that we can spend the resources that will be available to us, and that we will need to spend that money in a more enlightened way, given the constraints that we'll face in the future and given the likelihood of significantly increasing demand as a result of the COVID crisis.
Great, thank you very much, Norman. As you can see, two very different angles looking at this issue, but lots of things for us to think about. I've got a couple of questions already, but if other people would like to send in more questions, please use the Q&A button at the bottom of the screen. So the first question we've got is one from Diane Dean Bowers, who is a volunteer patient representative at the local hospital. And she's asked about diabetes and about technology. And actually both of you, both Norman and Andrew, you've both raised questions of technology and how we can actually either harness it for the future and progress that's been made and sort of those that get left behind. And this is a really interesting question, kind of looking at both of those angles. So Diane says that type 2 diabetes is a major risk factor for COVID severity. Type 1 patients benefit enormously from modern technology, which is not available to those who are suffering from type 2 diabetes. Would it be of benefit to the NHS to embrace the widespread use of all modern technology, which is shown to greatly improve diabetic management and severe complications? Who would like to come and answer on that first? Andrew.
I guess it's more acute than mental. So if I answer that first, Diane, yes. So I'm a great believer that we need to use technologies more than we are using them at the moment, but we need to use them obviously in a way that is evaluated, in a way that shows that they make a difference. And we've got to be thinking about using them on the population level as well as in the individual level. And these technologies are going to come in many forms. They're going to come in the form of, wearable devices, monitors, things that people use individually, as well as things like apps that might be motivating people to, for example, in type 2 diabetes, take control of their diet, take control of their exercise, and understand that one. But also much more digital monitoring. So in Northwest London, we have we are developing a very strong digital system that actually is being run out across London now, where we are able to really collect patient records in a confidential and appropriately ethically managed way, and in a way in which we are actually testing with the community that they are happy that we're using their records, and then using that in order to support individuals in improving their health. And this can both be by spotting areas where, for example, in type 2 diabetes, you might be looking and seeing where there are issues, or you might be spotting individuals who have particular risk whom you need to intervene in early. Because the key is in all of these ones let's identify the people who need help, let's intervene early, because that's the most efficient way financially, but more importantly, it's the best way to care for those patients. So yes, I agree, technology needs to be harnessed across it. And one of the things I really welcome in the HE report about future doctors is actually this is a role of doctors to actually go out there and source technology and understand the technology so we can use it to the benefit of our patients.
Thank you, Andrew. Norman, did you want to come in on that as well?
Yeah, not specifically on diabetes, because I don't have the knowledge of the opportunities available, but very much know what Andrew has said. But if I can interpret the question to also relate to opportunities in mental health. So I also chair an advisory board for a digital mental health company called Kooth. And fascinatingly, 3 weeks ago, they went through an IPO. So this is selling shares to the public. Highly successful, one of the first IPOs post-COVID lockdown. And the interesting point about that is that there is obviously very big interest in the market in the opportunities for investment in digital mental health support. So this makes a really important point. that, again, I come back to what I said earlier. This has to be about collaboration between public and private. Kooth provide platforms. They've become known primarily for their youth platform. So I think they now have contracts with about 85–90% of clinical commissioning groups. And in areas where they are contracted, any young person, any teenager, for example, can go onto the app. They can get access to a whole load of information, including videos, about what they may be going through themselves. They can enter moderated chat rooms so they can talk to others about what they're going through, which in itself can be often therapeutic. And they can also get access, one-to-one access to a counsellor. And they can do all of that without waiting a single day. They can go straight into it. We know that for many young people across the mental health system, they're left waiting up to a year for secondary mental health support. It's shocking and it's completely unacceptable, but that is the reality. And so enabling a cohort of young people who are experiencing mental distress, for example, to get immediate access to online support becomes highly attractive as part of the landscape of what should be offered to all people. Now, it's not just relevant to young people. Think about all those adults who may be going through significantly increased anxiety and distress as a result of potential unemployment. Getting access for them to digital support could be a lifeline and could be an absolutely vital element of support whilst they wait for something else to happen within the traditional system. So I think it just cries out for us to be willing to embrace technology as part of our landscape of support that's available to people. That those technology solutions have to be tied in to the NHS. The attraction of the Kooth model is that they link into their local NHS, so that if they identify someone online who may be experiencing significant and troubling mental ill health, they can be referred straight into the local CAM system. So that we have to embrace this. And of course, there is also the added attraction that support in this way can often be much more cost effective than traditional routes. And it has to therefore be part of the landscape of what's available.
Thank you both. It strikes me that this is also an area where there's definitely a role for universities to play as well.
Absolutely.
Working with providers and on the cutting edge of research, looking at how we can contribute as well to that dimension, and developing new technology and making sure that research is informing the development of those services as well.
Very much so, and in building up the evidence base as well. You know, we can try new interventions, but we have to test with robust academic evaluation to make sure that they are actually effective. We have to be willing to be creative about how we evaluate. Sometimes the randomized control trial isn't always appropriate or possible, but the need for academic evaluation becomes critically important.
I'd absolutely underline that point by Norman. I think that, you know, we have a very strong evidence base in general for our medicines that we use, certainly the new medicines that are introduced. Some of these digital ones are really exciting and have benefit, but we don't always have the evidence base that we need, which we need both to show it's the right thing, but then also to justify the funding for it. And it's going to take imaginative ways of thinking of how we evaluate these online and apps and so on and so forth.
Yeah. Thank you both. June Mulroy, who is connected to St Mary's as a governor, and also to the South London and Worsley Trust. June has asked if the NHS is there to help in times of illness, how will a rebuild help improve personal support for better health, both mental and physical? Who would like to come in? And
Perhaps I can come in to start with on this. First of all, June was my immediate predecessor as interim chair of the Maudsley, and did an amazing job in quite tough circumstances. So massive gratitude to June. But we've undertaken a piece of work which I think is potentially quite exciting. So during the height of the COVID lockdown, I had interesting discussions with Gregor Henderson, who leads on mental health for Public Health England. And he made the case to me that we need to have a sort of a policy response, a public mental health response to the psychological fallout from COVID, both at a national and a local level. So at the local level, I talked to people internally about the case for holding a prevention summit, which might then lead to collaborative work with local authorities, community-based organisations, third sector, and so on. We had that summit. Remarkably, we had over 1,000 people register to take part in it from the 4 boroughs that we represent. And it's now triggered the establishment of a task force. We're doing this jointly with our 4 local authorities, and indeed now it's spread to the whole of South London. We're working closely with third sector and with community and faith groups. And we're building a number of different potential interventions founded on public mental health. So supporting communities, helping communities to become more resilient, intervening much earlier, identifying areas of distress and responding to it quickly before people and communities fall into crisis. You can only do that through collaboration. And it seems to me to be incumbent upon mental health trusts to act as a sort of community asset, to collaborate with others to support communities much earlier. So I think this is an immensely exciting opportunity. We've got some funding from the ICS, the Integrated Care System. So there's a recognition at that level that this sort of more creative, collaborative approach is what's needed. We've put money into it. And I think this must be the way forward if we're to respond more effectively to distress levels in communities.
Thanks. Andrew, do you want to come in as well?
Yes, so thank you. And I'm really excited by what Norman just said there. I think also there's a real opportunity to carry that on for us to really build on the concept of NHS providers, both acute and perhaps particularly the mental health ones, becoming anchor institutes in the local community. Often they're seen as these great big white buildings sort of on the hill that you come to when you're sick. Actually, we need to be having them actually integrating with their local communities in order to develop health. So that's I think absolutely key. Picking up some of what June has said as well, I think there is stuff that we're going to have to do in the rebuild. I think behind this question there is this assumption that, of course, the NHS is actually a national disease service rather than national health service. And we do need to change that balance. There's no doubt about it. I think we need to change it for all sorts of reasons. Patient and population care first and foremost, but actually also financial. But we are dealing with a lot of very outdated stock, especially in this end of London, the west and north of London, where we have a lot of outdated stock. I think we've also got to start thinking about what COVID has done to our understanding of our physical plant. Is it actually laid out in the best possible way? We need much more flexible ways of doing it. COVID-19 has struck. There will quite likely be another COVID or another something else down the line, whether that's in 5 years, 10 years, 50 years, but we need to build our buildings so that they are resilient and are able to cope with that one, so that we can be flexible and so that we don't need to absolutely close down all of our operating theatres in order to keep the intensive care going in the hospital. So I think there will also be lessons to how we build our buildings as well as how we organise ourselves. Thank you.
Just to quickly pick up on what Andrew has said there, and I completely agree with it. The tendency in the past has been, when money is tight, to cut the preventive services. That's what the system does. You know, when money is tight, it's vital to keep the acute hospital going. So what do? You take a bit of money away from community services, from general practice, sometimes from mental health, and of course, then you don't stop the flow of more patients coming into the system in the future. And somehow we've got to square that circle and become better at preserving and protecting and indeed enhancing what we spend on the preventive services, the preventive end of the spectrum. And that includes, incidentally, social care. So that has to be a new settlement for social care. Please, government, please grasp this nettle, because it's been in the long grass now for 3 decades. But if you can enhance the preventive end of the spectrum, then in time we will reduce the flow of people into the acute end of the spectrum, and that must be what we all aspire to.
But Norman, do you think that there might be an opportunity here as post-COVID we have a population that are more used to thinking about the trade-offs that are inherent in healthcare, more used to thinking about the fact that actually there are choices to be made both as individuals but also as societies and communities, that we can have a more intelligent debate about this rather than a debate where, frankly, you know, a whole load of people protesting around the closure of a hospital service or something like that causes those very pressures that you've talked about. That means that we pile all of our you know, we concentrate our resource on those areas that you were talking about.
I totally agree, and we need to initiate that debate. And I think part of the solution also is devolving power and responsibility much more to the locality. I've just finished chairing what we called a health devolution commission alongside Andy Burnham. We chaired it together. And I think the Manchester experiment, the Greater Manchester experiment, is really interesting, because at a local level, they can concentrate much more on health, the health of the community, rather than on the delivery of health services. They can join up their approach much more effectively than a Whitehall-driven approach is ever going to be able to do. And they can focus more on the social determinants of health, to, you know, housing, education, employment, poverty, in order to sort of stem the flow of poor health in the future. And so I think that's got to be part of the debate as well, a shift of power to the locality.
Which leads very nicely on to another question that I have, which is around sort of health inequalities. I think it's striking, both of you mentioned in your introductory comments around health inequalities that existed pre-COVID. And Norman, you mentioned racial inequalities as well as part of that. And these have obviously got worse as a result, particularly the racial dimension has obviously got worse as a result of COVID as well. If we're trying to rebuild the NHS afterwards, and sort of taking into account the fact that we had a bad situation before which got worse, how can we actually create a system that sort of tries to design out some of those inequalities after the pandemic?
Do you want me? I don't mind who goes first on this.
Pass on to Andrew.
You go first, and I'll follow.
Let me just say a couple of things. So first of all, I welcome the fact that NHS England, in its sort of rather top-down edict way, which incidentally has been reinforced by this COVID crisis, it's, you know, command and control is back in fashion, unfortunately. And so I come back to what I said before, that actually the better solution is to devolve power rather than to centralise it even more. But that's what's happening. But at least in their top-down edicts, they are stressing the importance of confronting health inequality. So that's at least a help. They have grasped that this is important. And I just think that across the NHS, it has to be embraced. And it's one thing to say it, it's another thing to do it. I think that also means that the hierarchies within the NHS need to change as well. Someone was saying, I'm not sure, I can't verify this, it needs to be checked out. But if you look at boards of health organisations across Birmingham, I was told that there wasn't a single BAME person on any of the boards of health trusts in Birmingham. There are in London, but the numbers are far, far too low on the boards amongst NEDs, but also amongst executives on the boards as well. And unless you have a more representative leadership of the communities that we're serving, then we will never really quite get this right. So it does present quite a challenge to all of us to change how we look and to get different points of view, different perspectives heard at the board table, and to ensure that the local community is better represented in the upper echelons of our NHS institutions. We can't create a more equal health system if it's all driven by middle-aged white men. That's the reality of it too often still, and it has to change.
Totally agree with you, Norman. Andrew, would you like to come in as well?
Yes, no, I think so. My learning, my personal learning from this summer has been that it's actually not good enough to be colourblind. I think that that's something where I would have prided myself, a year ago, on the fact that I would have treated everybody as equal. And I think that what I've had to do, and I think a lot of us have had to do, is realise our responsibility for being part of a system that even if when people come through the door and sit in front of you, you treat them as equal, the system doesn't. And so we need to think about how we're going to do that one. And I think in the healthcare, there are many aspects of it. I think actually, again, going back to the point about funding different aspects of healthcare, I think in actual fact, it's interesting. And again, I don't have the, I think there's a research project to be done there, but having recently become involved in a mental health trust, looking at the ethnic makeup of and the demographic makeup of the population who are that mental health trust are serving, I think that is different from that which many of the acute hospitals are serving, and that we are actually concentrating our resources on particular needs, and those needs may not be representative of our whole society. And I think there's a piece of work to be done there. There's also, of course, a piece of work that needs to be done that actually also realises that that this is not something the NHS, you, Jenny, as the universities, I think the government's very good at hoping that the NHS and universities can solve all of the world's problems, all of the inequality problems of the entire one. Many of these health problems that we are dealing with are embedded in our society, which is larger than the NHS. And therefore we need to take that bigger picture, and we need to understand I think we have a position of in the universities is sometimes to call those things out so that they become visible, so that they can then be dealt with. But we can't actually, it's not for the NHS to solve the whole housing problems, even though that's a major determinant of healthcare.
It's a very good point that you make. I've got two more questions, which we might try and sneak in before the end. The first one's from Duncan Hames, who is also involved in South London and Maudsley, and is a former colleague of mine and Norman's. What do you think will be the impact on public expectations of associated digital services from their experience of them during COVID? And does this extend to more open and intensive health and wellbeing monitoring? I don't know if either of you would like to comment.
I'm happy to.
Yeah.
Go on, Andrew.
I think that accepting the point that Norman made earlier, that there will be some people to whom this is not going to work because of their connectedness. I think that all of us have, all of us have got much more, most of us would not have been happy taking part in a Zoom webinar 6 months ago. So actually, I think that the public expectations of what's being provided are going to be much more up to date. Why are you having to schlep into a hospital and travel 2 hours towards a hospital in order to have a 10-minute appointment for somebody to look at your notes and say, come back and see me in 6 months' time? Bonkers. So I think that there will be, amongst many people, a much greater impact on expectation of that one. And while what the medical profession and the hospitals have done and the GPs have done in the short term has been frankly quite miraculous how quickly we've been able to move into that sort of area, we need to actually think through what does it mean, what actually does a telephone or a remote consultation is. It's not just the same as a face-to-face consultation, but you're on one end of it. What can be done? And I think you're going to actually have to look at the patient journey. And I think we will see patient journeys where people are touched in a physical sense less by the medical profession, but touched perhaps more often in a digital way, and then actually working out when does a face-to-face contact actually make a big difference. Is it at the beginning? Is it in the middle? When is it in that journey that is actually the moment you get the best value, the patient gets the best value out of it?
Thank you.
And I think triaging becomes critically important. My sister is a GP, and she has extreme concerns about the complete digital by default approach. I happen to be a very strong advocate of virtual consultations playing their part, but she makes the legitimate point that the good GP observes how someone moves, how they walk into their clinic, how they sit down, how they stand up, their mood, their body language. All of these things can tell you a lot about the patient and help you to diagnose or to identify concerns that might need a diagnosis. And the risk is that we miss some of the nuanced sort of opportunities that the physical presence offers you that virtual cannot replicate. And so this is not a one-size-fits-all. And so careful triage by skilled professionals about who is appropriate for a virtual consultation and who needs to be seen, I think is absolutely critical.
Thank you. And in the very last minute, Anthony McLaren, who's the Vice Chancellor at St Mary's, has asked, how can we respond responsibly and with the health of the whole community in mind to current media concern about the return of students to their universities? Very topical, off the top of all of our minds today. Norman or Andrew, which one of you got some advice for us?
Well, this is all a bit of a nightmare, to be honest. I heard a student on the radio this morning who had been requested to return to university, and now all she's getting is 3 hours of digital learning and no social life. So this is hopeless. And the universities need the income from the fees. But the students legitimately can say they're not getting value for money from the amount that they're investing in their futures. And so government, I think, will have to intervene here. But how they do it and how we can finance that is a bit of a nightmare.
So I'll give a long-term answer, and the long-term answer is that in the same as the NHS, the university system has been immensely stressed, obviously, by the whole of the COVID thing. I think it has brought to the front issues with the university system, where in actual fact our current university system is not totally sustainable, and it's actually brought those fracture lines to the fore. Yeah, and so I think, again, we've got to sit down and think, what university system do we want in the future? Yeah. I don't think our current university system, frankly, is sustainable. And I think that the universities that think imaginatively and think of a way through what they're going to do will offer a totally, will have an immense advantage. I mean, that doesn't help you in the next week, Jenny. But I got involved in a private university, and so I said, could I observe some lesson sessions? And they said, yes, you're going to have to do it though on a Saturday or Sunday, because they do all of their teaching on a Saturday and Sunday, because these are mature students who are working the rest of the time. Now, any university that I've been involved in would struggle to deliver that. So, you know, I think we need to think what are we trying to do with our university education?
Totally endorse that.
Good universities.
Well, thank you very, very much to both Andrew and Norman. I hope you have, all of those attending, have really enjoyed that. I think it's given me lots and lots of things to think about. And St Mary's is doing a series of different webinars looking at life after COVID. So thank you both to Professor Andrew George and to Sir Norman Lamb for contributing, thinking about the NHS today. Thank you very much, both.
Thanks a lot.
Thanks
Thank
for
you.
attending. Thanks.
Bye-bye.